Hey everyone, welcome back to my channel Whitecoats and Corgis. You probably know me from Instagram or TikTok where I post helpful content for pre-meds who are trying to get through the application process to medical school. In this video, I'm going to be showing you a couple different doctors who are making the most money out of any specialty in medicine. These doctors are going to tell you a little bit about their specialty, how much money they make, and what they do on a day-to-day basis.
So about neurosurgery as a specialty in general. So a way to kind of think about it is that we're kind of tasked with the diagnosis and treatment of disorders of the nervous system. That includes the brain, the spine, peripheral nerves, and the vessels that supply them. A lot of times, it's true of me too. I thought of neurosurgery and I thought brain surgery, but it's so much more than just brain surgery. There's spine surgery is extensive and super interesting in and of itself, as well as peripheral nerve surgery. And knowledge of and appreciation of all of those is essential in neurosurgery. Things that I'd want to point out about the field itself, it's very integrated. And what I mean by that is it doesn't rest on just a knowledge of how to do the procedures, how to do the surgeries. The patients who you treat as a neurosurgeon can be very sick, and a knowledge and an understanding of ICU medicine, critical care medicine, is essential in understanding what's happening to your patient and how best to manage them. So we really we emphasize not just the knowledge of surgery and anatomy and all that, but really ownership of the medical side of things as well. And then along with that, along with the sort of the surgical and operative understanding is in understanding neuroradiology. We spend a lot of our days scrolling through CAT scan, head CTs, MRIs, and that kind of thing, and both understanding what's happening to the patient, but also trying to understand if there is something that we can do surgically to help them. And all this happens across the lifespan in neurosurgery. So there is the field of pediatric neurosurgery, which we all, as residents, all get exposure to, and you can choose to specialize in it, all the way to 90, 100-year-old patients who have a fall and have some sort of trauma, and they need to see a neurosurgeon and have that managed. It's a young discipline. A lot of the advances that kind of founded the field happened around the turn of the century, around the 1900s, and as a result of that, there's the field has advanced very rapidly in that time, and there's very much this focus on on trying to make the field better, trying to push it forward, and that's both in the sense of surgical technology, but also how can we understand the pathophysiology of the diseases that we're treating, and as a direct result of that, as I was mentioning before, there's definitely this focus, especially in academic neurosurgery, on research that advances the field. And lastly, it's a small field. There's only about 3,500 practicing neurosurgeons in the country, about 100 residency programs. So those numbers are a lot smaller than some of the bigger residencies. And as a result, as mentioned before, that there's a lot of people in the field really know each other, and it's very tightly regulated, such that you go to a residency program and you're going to get well trained. You're going to, like anything else, you're going to get what you put out of it, but they're regulated such that you're going to see the surgeries that you need to see and get the experience that you need to get, because there's generally just so few programs. The subspecialties within neurosurgery, it's already seems like a very subspecialized field, but there's there are many subspecialties within it. The main ones here, so tumor being brain tumors are kind of, you can specialize specifically in the surgical treatment of brain tumors. Cerebrovascular disease, that's a field that needs its own fellowship, and basically combines endovascular treatment with open surgical treatment of vascular diseases, things like aneurysms, arteriovenous malformations, cavernomas, things like that. Skull base neurosurgery deals with pathology, obviously around the skull base, which is a very complex region anatomically, some of the best anatomy in the human body, no bias here, but something else that you can further specialize in and deal specifically with surgeries that are dealing with that region. Pediatrics, as I mentioned before, that's another subspecialty that you need a fellowship for. Spine within itself has a couple of different pathways. There's minimally invasive, which kind of leverages a lot of new technology that's coming out recently, which has kind of redefined the approach to the spine. And deformity, which is correction of really things like really bad scoliosis, kyphosis, things like that, which can really improve the quality of life of people who are suffering. Functional neurosurgery is another just rapidly expanding field that's changing, really, it seems, by the day. And what this entails is probably some of the videos that you've seen of deep brain stimulation when people have a stimulator put in the OR and their tremor goes away such that they can play a violin or do things that they just never could before. This field also deals with epilepsy, the treatment of refractory epilepsy, and along with movement disorders like Parkinson's disease, there's this rapid expansion to attempt to treat refractory psychiatric disease with surgical intervention as well. So definitely a lot of really exciting things happening in functional neurosurgery. And then peripheral nerve surgery is the treatment of things like tumors of like the peroneal nerve or carpal tunnel syndrome, nerve transfers. Patients who come in with after really bad trauma may have a brachial plexus avulsion, and they can get their brachial plexus, certain nerves grafted to in an attempt to restore function. So basically, the point here is that there's a really sort of broad practice within neurosurgery, and in residency you get exposure to all of this, and you get really a better sense of what it is that you're truly interested in.
What is orthopedic surgery? Orthopedic surgery is the treatment of musculoskeletal disorders, and that includes the treatment of bones, muscles, ligaments, tendons, nerves, and the skin and soft tissue. It's fairly comprehensive. It includes just about everything outside of the head and the abdomen. But I do know some orthopedic surgeons that will venture into the back part of the skull and the front of the spine here, and also we'll do some rib surgeries, as well as some abdominal flaps. So it doesn't necessarily limit you to these things. I think the field of orthopedic surgery is very wide and almost all-encompassing. Treatment is largely geared at restoring function and eliminating pain. There's many reasons why people seek out an orthopedic surgeon. Typically, we all think of a broken bone as a reason to go seek out an orthopedic surgeon, but chronic debilitating arthritis, low back pain, numbness and tingling in the fingers, these are all reasons why people seek out certain subspecialists. Pain is usually one of the reasons why people seek out help in the first place. And then when the etiology of that pain is deemed to be something that's related to the musculoskeletal system, often those patients are referred to us. Orthopedic surgery requires an in-depth knowledge of many surgical subspecialties blended into one: principles of general surgery, plastic surgery, neurology and neurosurgery with peripheral nerve surgery, physical medicine and rehabilitation, and even physical therapy. So it is a fairly wide encompassing practice. I think these are some images that are representative of some of the types of injuries that we see on a not so irregular basis. This is, I think, what classically comes to mind when people see or think of an orthopedic surgeon. We deal with a lot of radiology and medical imaging. These are x-rays of various body parts, ranging from a forearm on the left to a distal humerus in the bottom right-hand corner. And then this is the bottom middle image on the left is probably what Tiger Woods just had, and that came out in the news recently. He had a shattered tibia and a fibula fracture. So that's a part of the lower extremity. And I think these are classic images of what we think of as orthopedic surgeons, but it's not just that. Orthopedic surgeons then treat these fractures and broken bones and problems with a variety of tools. We call those implants or medical devices. Usually they're made out of a stainless steel alloy or titanium in some instances, or various blends of metal. And these may be representative of some of the things you can pick up at Home Depot. We put in plates, we put in screws, we put in bands, we put in wires, we put in rods, and these are all part of our literal toolbox. From a day-to-day, what does the life of an orthopedic surgeon look like? Well, I think there's significant variety based on a specialty. And the specialties within orthopedic surgery are many. There are hand surgeons, there are joint replacement surgeons, there are spine surgeons, there are foot and ankle surgeons, there are sports trained surgeons, there are fellowships in trauma surgery, shoulder and elbow surgery, a newer burgeoning field that's a hybrid between neurosurgery and plastic surgery is called orthoplastics, or reconstructive microsurgery. That deals with connecting cut nerves and even doing nerve transfers to increase or provide functionality to patients' limbs. There are general orthopedic surgeons, so people that just do a little bit of everything. And then there are orthopedic oncologists, so tumors of the musculoskeletal system. And then finally, there is a field dedicated just to children and pediatric orthopedics. All of these are fellowships that you can do after you finish your orthopedic surgery residency training. And we'll talk about the residency and fellowship process in just a minute. But the day-to-day life and what types of patients you see as an orthopedic surgeon can vary tremendously based on your type of practice and also what kind of surgeon you choose to be. If you're a general orthopedic surgeon, you'll see a little bit of everything that walks through the door. In today's day and age, I think there's a trend towards increasing subspecialization. So within the field of orthopedic surgery, you'll have at a single hospital or a practice, you'll have multiple fellowship-trained orthopedic surgeons, each covering a different domain of the body. So the hand surgeons will deal with the upper extremity. The joint replacement surgeons will typically do joint replacement surgery and complications that may arise from that. Spine surgeons do spine surgery. Foot and ankle surgeons do foot and ankle surgery, et cetera. That is increasingly common as time goes on. There is a mix of inpatient versus outpatient surgery. There's an increasing trend towards the ability to operate as an outpatient. So patients come in, they do a regional anesthetic, meaning that they have a peripheral nerve block from the anesthesiologist that numbs their extremity that they're getting operated on. They have the surgery, which could last, less than an hour to multiple hours, and then they go home the same day. That's termed outpatient surgery. Inpatient surgery typically is reserved for more complicated or risky procedures, or patients that may be at a higher risk of having surgery. So they either have multiple comorbidities that preclude them from being operated on as an outpatient, or they may have multiple traumatic injuries and they may not be stable enough to have surgery done as an outpatient. Say, for instance, a patient who got into a motor vehicle accident that has multiple problems and not just musculoskeletal complaints. So say maybe they have abdominal injuries that general surgery or trauma surgery is managing, but they also happen to have a forearm fracture. Well, those patients typically will be managed in the hospital until they are well enough to be discharged outside the hospital. So as an orthopedic surgeon, you will manage both inpatient and outpatient surgeries. And then finally, there are multiple types of practices, and it's largely up to you which type of practice you wish to join. You can do academic medicine, where you work at a major academic medical center. And typically, academic orthopedic surgeons are subspecialized, and there may be multiple subspecialists within your own department. You can still go into private practice. Private practices can be multi-specialties. So you may have any of these varieties of specialties in your practice, or it could be single specialty. You could join a predominantly upper extremity practice, or you could join a predominantly sports practice. And even you could just be a surgical practice, and you could have orthopedic surgeons and also urologists and ear, nose, and throat doctors also working at the same surgery center that you may have a share or stakehold in. And then finally, there are orthopedic surgeons that are employed physicians. So they're employed by a hospital system, and there are many hospital systems throughout the country. That's typically how orthopedic surgery works, and the variety of practices that exist. So what is my data, or how much, I guess we should go on to that. How much do orthopedic surgeons earn? Typically, they're at the higher end of the spectrum. This varies from year to year. In this particular year, orthopedic surgeons were at the top of the list. Now, if you go into subspecializations, increasingly at the top of the list, there are interventional cardiologists. So who place minimally invasive, who place stents and other valve replacements minimally invasively. And neurosurgeons or spine surgeons also tend to be at the top of the list. This is, in general, this list here is general practitioners. So in general, orthopedic surgeons are well compensated for what they do. I would say the average orthopedic surgeon probably works about 60 hours a week. That's about 12 hours a day or less, but then taking call on the nights or the weekends. So I think from a work-life balance standpoint, it's very good. I don't have any complaints about my work-life balance. I think in any profession, your work-life balance is what you make of it. You can do anything you want to as a physician, and you can be as busy or not as busy as you wish to. And I wouldn't shy away from joining a surgical subspecialty or a surgical specialty because you think that you're not going to have enough time to have a work-life balance. I think the field of orthopedic surgery is increasing. It has historically been underrepresented by women, but that trend is reversing, and there are increasing numbers of women that are choosing to go into orthopedic surgery and many surgical subspecialties outside of orthopedics. I think it's a phenomenal field for just about anyone who wishes to do that. And so the work-life balance, I think, is fine, and they will differ depending on what type of orthopedic surgeon you are. If you are a trauma surgeon and you are on call more, you may not have as much of a work-life balance as someone who operates almost exclusively at an outpatient surgery center, where those typically are open only between the hours of 7 and 5 p.m. So that's a little bit about the lifestyle and compensation of an orthopedic surgeon. How do you become an orthopedic surgeon? Well, you have to match into an orthopedic residency, and then fellowship is optional. I think most people choose to do a fellowship these days, and I think for good reason, because we're increasingly subspecialized, but the number of surgeries and what we can do as orthopedic surgeons is expanding on a day-to-day basis. The operations that we were able to do 20 years ago are far and few between compared to the operations that we can do today. And I think the number of surgeries and the scope of practice that has increased offers the increasing interest in doing more training. And some people choose to do even 2 or 3 fellowships because they want to become a certain type of subspecialized surgeon that only specializes in, say, hip preservation surgery or a specific type of pediatric surgery. Typically, an orthopedic surgery residency will have 1 to 14 residents per year. There are about 120 plus programs in the United States, and about 800 to 900 residents will match per year. It is competitive. I would say that's probably about 75% of the applicants. So 25 to 35% of people will end up not matching into orthopedics and will have to either reapply or do something else. Orthopedic surgery residency is 5 clinical years. As an intern, you'll do 6 months of general surgery and other rotations that are foundational for the practice of orthopedics, including radiology and managing patients in an intensive care unit. Some programs do have an optional research year for interested residents. So though that makes their residency program 6 years. Typically, those slots you have to apply to directly. So if you're interested in doing a research year as part of your residency program, you may have to apply specifically to that spot at that program. Intern year typically is a mix of floor management and the introduction to the operative experience. Each program introduces their residents to the operative experience differently. Some programs will have a large operative component to their intern year, and some programs will not have a large operative component to their intern year. Intern year is important for you to learn how to take care of patients after surgery, before surgery, and any complications that are medical that arise from surgery. PGY 2 year, or the second year of residency, is typically the consult year. So you carry a pager. And when there are emergencies or traumas, such as the one that we saw previously on the slide previously, when those come into the emergency department, you usually are the first line clinician. They will call you and say, I have an orthopedic consult for you, and you will go see that patient in the emergency department. There is a trend towards adding increasing operative responsibilities as a second year resident. And then years 3 through 5 typically are largely operative. You usually will still have a mix of call in there. You will have chief resident responsibilities, and you will be directly responsible for directing the management of patients that come into the emergency department. You may not be the one physically evaluating the patient, but your junior residents, when you're a chief resident, will run consults by you. They'll call you and they'll ask you for your help. They'll ask you what to do with the patient. There's sort of a ladder approach to managing patients and determining how to treat them best. And then when you graduate, you have the option to complete a fellowship. All fellowships in orthopedic surgery are 1 year. There are a handful of 2-year fellowships that typically add on a research component, but that's not common. So any of the fellowships that we previously talked about, sports, foot and ankle surgery, spine surgery, all of those are 1 extra year of subspecialization where you pretty much just do that type of surgery.
All right, so plastic surgery today, there are a lot of different subspecialties. Microsurgery is probably one of the biggest bread and butter aspects of plastic surgery. Microsurgery refers to using either loop magnification, so those glasses with lenses you see people wearing, or an operating microscope. And this refers to reconnecting blood vessels or nerves for a variety of different purposes. A major thing that we do is oncologic reconstruction. So after breast cancer, head and neck cancer, skin cancers, soft tissue tumors, bone tumors, anything. Limb salvage is similar, reconstructing the limb after you have either cancer or trauma or some kind of wound, like a diabetic foot wound. Lymphedema surgery, it's sometimes called super microsurgery. It's where you're reconnecting blood lymphatic vessels, and these can be 0.3 millimeters, so very small. Hand and upper extremity is another subspecialty that is actually shared with orthopedic surgery. So hand surgery, it refers to surgery distal to the elbow, and you can go into hand surgery either through plastic surgery or through orthopedics. This deals with bony diseases of the hand, also, soft tissue problems, reconstructing the hand as well, amputations and reattaching fingers or hands. Pediatric hand refers to congenital pediatric hand deformities, like the syndactylly shown here. Brachial plexus, so helping to repair reconstruct the brachial plexus for injuries. Peripheral nerve surgery is also important. I put it under hand surgery, but this refers to nerves all over the body. So patients who have either nerve injuries or painful neuromas, migraines can be treated surgically. Also, like things like pudendal neuralgia, decompressing nerves around the body. Aesthetic surgery, as we all know, so this is body contouring after massive weight loss, facial aesthetics, and most people are familiar with this aspect of plastic surgery. Transgender surgery, this is top surgery and bottom surgery for male to female and female to male. Craniofacial and pediatric are often lumped together. So this includes adult craniofacial trauma, but it also includes pediatric craniofacial surgery, which includes things like soft tissues, so cleft lip, but also bony deformities like craniosynostosis and other skull conditions that kids may be born with. Orthognathic surgery refers to surgery of the jaw and the mid-face. This can be for either facial aesthetics, for changing the shape of the jaw or the mid-face, or for things like opening up the airway if they were born with, issues with breathing. So I put this category here for other reconstructions. So this can include burn reconstruction, complex wound reconstruction, trauma reconstruction. And then finally, I put vascularized composite allotransplantation here. So, as we discussed on the last slide, you began with the first kidney transplant in the 50s, and now we have transplant surgery as its own specialty, and they're performing whole organ transplants. Plastic surgery today is very focused on the idea of composite allotransplantation. So this means transplanting composite tissue, so multiple tissue types together. And so this is mostly seen in face transplants, hand and upper limb transplants, abdominal wall transplants for patients who, have massive abdominal wall defects from either a tumor resection or from a military blast injury, penoscrotal transplants as well. On a daily basis, we share patients with, all these different groups. I would say at my institution, we mostly cooperate with orthopedics and neurosurgery a lot. We do a lot of limb cases with orthopedics and peripheral nerve cases. And we also do a lot of spine and skull cases with neurosurgery. I do want to clarify some of these other specialties that people often hear about. And so this is, first we have oculoplastics. So if you are interested in plastic surgery of the orbit, so this includes aesthetic eye surgery, but also things like orbital wall trauma, then oculoplastics is another field that you can go into through ophthalmology. Facial plastic surgery refers to aesthetic surgery of the face and also reconstructive facial surgery. And this is a subspecialty after otolaryngology residency. Head and neck reconstruction similarly is after ENT. And orthognathic surgery or jaw surgery, as we mentioned, is shared with oral surgery. And finally, I have cosmetic surgery listed here. And this is worth noting that this is distinct from plastic surgery. And cosmetic surgery is a specialty that you can go into even without training in a surgical residency. And just of note, it is not recognized by the American Board of Medical Specialties.
Hi again, my name is Q. I'm a fourth-year resident in radiation oncology at the University of Arizona. Just to start off with, I wanted to discuss a little bit more about the field itself. So as many of you already know, oncology is the study of cancer. And cancer is usually suspected by primary care providers, emergency medicine providers, and hospitalists based on clinical presentation, abnormal lab values, and imaging findings. But to ultimately confirm a diagnosis of cancer, someone has to obtain tissue, so either a surgeon or an interventional radiologist, and a pathologist confirms the findings of cancer under the microscope. Treatment is multimodality. Surgeons take care of a lot of cancers by cutting it out. They aim for getting a negative margin. And then medical oncologists take care of cancer either through chemotherapy, immunotherapy, targeted agents, or hormonal therapy. That leaves what I do, which is radiation therapy. And radiation therapy utilizes ionizing radiation. Sometimes it's from a source such as iodine or cobalt, and sometimes it's generated through a linear accelerator or a particle accelerator. These methods are different ways to create free radicals that can destroy the cancerous cells, or they can damage the DNA of the cancer cells, making them have a difficult time dividing and spreading. So regarding radiation, it's very useful in cancer because it's very focal. We use our targeting systems, our mapping systems to localize the cancer and carve out a specific shape of the radiation beam so that only that is targeted and we can spare as much of the healthy tissue as possible. It's also good because sometimes a patient is unfit for surgery, or it's in a place that cannot be removed, or there's some leftover tumor cells after the surgery. So it cleans up what surgery does sometimes. And there's an interplay between radiation and systemic therapy, such as chemotherapy or immunotherapy. Oftentimes, treating cancer requires a combination of the three. And radiation can be used to cure cancer, but it can also be used to palliate cancer, meaning alleviate pain or other symptoms or prevent complications such as a cord compression from occurring. So it does require a medical degree. obviously, and then that's followed by 5 years of residency. I talked a little bit about it earlier, but I did my first year in internal medicine, and then years 2 to 5 are dedicated in radiation oncology. Most of it is outpatient based, so it's a lot like any other outpatient service. You work directly with an attending physician. You see the patient first, you develop a plan, you present to the attending, and then the attending sort of goes over your plan, and we rotate through the different sites of the body. So CNS, pediatrics, head and neck, gynecology, thoracic, skin, GU, musculoskeletal, GI, lymphoma, and rotations are generally 2 to 4 months. And we usually do like at least 2 rotations for each disease site before moving on. It's a very good quality of life. Even during training, we rarely exceed over 60 hours per week, which sounds a lot, but as a busy pre-med, I'm sure you can definitely handle that. And then weekends and holidays are usually off. There's minimal call. And there's also ample time for electives. So if you're really interested in research or learning to do different types of procedures, or even going abroad to learn about machines that other countries have that the US doesn't quite have yet, there's definitely ample time for that. Once out of practice, most people do go into a private or community setting. In those cases, unless they work in a very big institution or hospital, they're usually in charge of treating all sites of cancer. And common things being common, most of a radiation oncologist's practice is breast cancer, prostate cancer, and palliative cases, such as like bony metastases or brain mets. And then the remaining quarter would be like all of the other sites that aren't breast or prostate. It is a very academic heavy field. So 20% of practicing physicians are in academic settings. And the clinical work is pretty similar, except they generally focus on one part of the body. And then subsequently, they do their research and their teaching on that part of the body so that they become more and more of an expert in that specific site. There's generally 5 components to what a radiation oncologist does. The first part is a consultation. We are a tertiary service, so we depend on referrals from other providers, other oncologists and surgeons. And most of the time it's from an outpatient setting, but sometimes there are cancer-related emergencies where our consultation and treatment takes place in the inpatient setting. The next part is a CT simulation, where we begin the treatment planning process. We put the patient in a position that that optimizes exposure of their cancer while also moving other body parts such as the arms. Sometimes we ask the patient to hold their breath. Sometimes we ask them to lay on their stomach so that other organs that don't have cancer in it are out of the way as much as possible. Sometimes even a matter of a few millimeters makes a big difference as far as side effects. After we get the CT scan from that, we do what we call planning. And the first part is contouring, where we draw out the tumor. And then we also draw out the organs we're trying to avoid side effects from. We work with our dosimetrists to come up with a plan that optimizes treating the cancer but minimizes toxicity. And then once the plan is ready, we treat the patient. And treatment can last anywhere from just 1 day. And really in 1 day, I really mean like 20, 30 minutes to 20, 30 minutes a day for 9 weeks. It depends a lot on how sensitive the area is and how slowly we can safely go to get away with not causing severe side effects. And then during that time, we also manage their side effects if they come up. And finally, we're very involved in the follow-up of the patients. We're usually the ones who order follow-up scans and manage long-term side effects. And we do what we can to make sure that the cancer doesn't come back. And if it does come back, we can address it as soon as possible.
So here's my presentation I have for you guys. So you want to do cardiology. So what I'm hoping to do here today is to give you a little bit of insight on how you get to become a cardiologist, what's the training involved, what's the various avenues you can take after you go into cardiology? Because it's cardiology, but now in this day and age, we're really compartmentalized and subspecialized into numerous different facets of cardiology, which makes it so interesting and exciting. And there may be something for everybody there. So we'll talk a little bit about that, the training and the time of training involved, and a little bit of insight of what my job is like. And then we're going to go over sort of a typical type of bread and butter case for someone in interventional cardiology like myself. Okay. So becoming a cardiologist. Well, first thing you got to know, there is a lot of schooling and training involved, right? And there are some fields that require less training. Interventional cardiology is pretty much the same as becoming a neurosurgeon, and there's a lot of training. So you obviously got your 4 years of undergraduate, you got your 4 years of medical school. There are 7-year combined program options, which I had considered at one point. In retrospect, I wish I had considered it strongly because, like I told you earlier, every year counts once you hit your 30s and 40s. Training, so 3 years of internal medicine residency, 3 years of cardiology fellowship. For the most part, there are some programs that have a sort of combined internal medicine fast track cardiology where they do it in 5 years. There's not a lot, but there's some. There's also some on the opposite spectrum cardiology programs that have 3 years plus 1 or 2 research years if you really want to go the intense research academic route. And so, it really depends what you're looking for. After general cardiology training, then there's further subspecialty training that can happen, which is 1 to 2, maybe even 3 years, depending on what you're looking for and what type of specific subspecialty you're interested in. And then there's always the optional research years that you can do. Some people tack on actually additional years in between residency and cardiology. For example, sometimes people don't match into cardiology, so they do some other ancillary cardiovascular imaging or echo or some kind of training programs you can do before fellowship, actually. So there are options for that. So there are a lot of different ways to get to it. And of course, other extra years. A lot of people do a chief residency year that acts on the extra year. Doing a chief resident year definitely improves your application, your chances, particularly if you're looking to stay at your own particular program to carry on. And again, we talked about the research years, and I took a research year between college and med school. Folks do that, and that's something to discuss with your college advisor if they feel your application could warrant it. Definitely one of the most competitive specialties. We talked a little bit about this before. A lot of things that do matter. Obviously, medical school and your scores in medical school are very important. The residency program you go to is important. Your UCMLE scores, although this day and age now we have a pass-fail for UCMLE step 1. So things are changing a little bit there. Research experience and letter of recs, perhaps even more important now with the pass-fail of USMLE. So, and this is always a moving target. And this is just a small snapshot. There's a ton of other things and ways to sort of help improve your chances of getting into a cardiology fellowship. So talk a little bit about cardiology subspecialties and the training involved. So we talked a little about the cardiology fellowship, right? So that's 3 years in general, okay? A lot of people, I don't know the exact numbers, how many people actually go into subspecialty. It definitely varies by year to year. Interventional cardiology, clearly one of the more popular and still probably the most common subspecialty in cardiology that people choose. In general, bread and butter interventional cardiology is 1 year. And sometimes extra training for an additional 1 year if you want to do more advanced training. So, when I was there was just interventional cardiology. Now they're having more accredited programs for additional training for structural interventions, and she'll talk a little about that later, and peripheral vascular procedures as well. So there are various models of additional training that can occur. Then there's the second most popular subspecialty is electrophysiology, right? So, interventionals, we're the plumbers of the heart. The electricians are obviously, the electrophysiologists rather are the electricians of the heart. That is now, used to be 1 or 2 years. Now it's pretty much around the board 2 years. So you're looking at 2 years of training if you want to do electrophysiology. What's becoming more and more popular also these days is advanced heart failure and transplant, right? So those are, and we'll talk a little bit about what they do, and most of those programs are also 1 year. And then advanced imaging specialists. With the advent of more usage of cardiac MRI, we're seeing a lot more of these trainings pop up as well. So that's also an additional year for cardio advanced imaging. Okay, and then there's other niche specialties. Some of these have, not all of them have accredited training programs, but you can find some non-accredited ones for more niched training that can include anything from adult congenital heart disease, cardio-critical care, which is a lot of people have been combining cardiology fellowship with a critical care fellowship, and there's actually like additional training after cardiology to do critical care. Cardio-oncology is also becoming, buzzworthy these days. Sports cardiology, this is just to name a few. And there's even subspecialty things that programs make up on their own and train people in. So you can really sometimes find a really innovative and, types of niches of subspecialties if you look around for it.
All right, so we're going to talk today, spend about a half an hour, starting off with why vascular surgery. And I'm going to talk to everybody about, what it's all about to be a vascular surgeon and what vascular surgeons do. And then we're going to actually present a couple of my cases, a couple of interesting cases, things that I've been thinking about, professionally for 40 years, things that I'm excited about, that I like, that get me up, that used to get me up every day, can't wait to get to work. And that's just a great feeling to have in one's career. So off we go. So we're going to talk today a lot about blood vessels. And blood vessels, as everybody knows, are the pipes that go throughout our body that blood is pumped through. And it all starts at the left side of the heart. They go out through the red blood vessels, obviously, which are the arteries, and they are then connected through a capillary bed to the blue blood vessels or the veins, and then the blood is returned through the veins back to the right side of the heart. And in the middle there, where the capillary bed is, that's where the oxygen unloads off of the red blood cells and nourishes all our tissues. So that's fundamentally what arteries and veins are and what they do. And as I said, they are generally paired. They go together and are often have the same name, but not always have the same name. But the red ones obviously come from the left side of the heart. They go out to the body, in this case, the arm, and then return back through here, back to the right side of the heart. Obviously, blood vessels go everywhere in every part of the body, and vascular surgeons take care of patients with diseases of these blood vessels in every part of the body. And that's why I kind of wanted to show this, that I work all over the body, not just on a knee or just on a hip. I'm all over the place. The only place that you won't find me is in the skull. We don't work on the brain or the blood vessels within the skull. And we also don't work on the two arteries in your heart, the coronary arteries, the right and left coronary artery, and their branches. So that's for vascular, that's for cardiac surgeons, and we're just working on all other blood vessels. So what does a vascular surgeon do? We comprehensively treat patients with diseases of arteries and veins in every part of the body except the heart and the brain, which is what I said. The key words in this definition for me are comprehensively, that we do all aspects of treatment, and there are other specialties that treat vascular disease, but only can do certain things. They can't do everything. And vascular surgeons, this is why I like vascular surgery, this is why I really loved it, is we could do everything when it came to taking care of patients with these problems. So again, it also refers to, we talked about patients, we're treating patients, we're not treating diseases, and we're treating them with problems in arteries, veins, and every part of the body. And the three fundamental modalities that we use are, we're doctor, even though we're surgeons, we're physicians, and we can prescribe certain medications. And that is a part of my practice and a part of what I do. But the much larger part of my practice is surgery, or in this case, this is a vascular stent. We're going to show a lot more pictures of this, so not to worry. Vascular stent, and this is called endovascular therapy, or endovascular treatment. We're going to talk about the differences here. So again, I do prescribe medications. It's part of what I do, but I'm a surgeon. And so what I do is I do interventions. I operate on people, or I treat their blood vessels from the inside, which is what endovascular surgery is. It's treating vascular disease from the inside of the blood vessels as opposed to the outside of the vessels. So this is a photo of this is an operative photo of a carotid endarterectomy, and I'm sure Daniel has seen this before. At least I hope he's seen this before. This is the carotid bifurcation. So this is a little incision made in somebody's neck, and this artery here, which is the internal carotid artery, goes up into your brain, and it's the main blood supply for 80% of your brain. You have one on the right and one on the left, but between those two, you're talking about that's your blood supply for your brain. And this patient had a blockage right here, right at this so-called bifurcation. And that's where blockages always occur, is generally at bifurcations of blood vessels. And this patient's already had the cleaning out of it. And the reason I know that is because there's a little vein patch here you can see that's sewn right onto the top of the artery. You see that how this is a little lighter in color, doesn't look exactly like this part of the artery. So this is a little vein patch that we sew on at the end after we've cleaned out the blockage, the blocking atherosclerotic plaque. So these are the two worlds that I live in. I live in this world and I live in this world, and we're going to talk about both of those as we go forward. But before we get to the cases, and we're going to illustrate those two things as we talk about the cases, let's talk about the path to vascular surgery. And the reason I put this slide up is that I live in Delray Beach, Florida, and I haven't seen a scene like this in 3 years. So this does not look like South Florida. So which is why I wanted to put it up for just a change for me. This is an interesting slide. I'll bet Daniel and Sam get a kick out of this. And I came across this as I was preparing this presentation. I actually had never seen it before. And this is like, how do you choose what specialty you go into? So here you are, you're a medical student. And if you can then decide, are you sane or are you crazy? If you're crazy and you have no attention, you have a significant attention span, you should become a psychiatrist. But if you're crazy and you don't have any attention span, you ought to be an emergency medicine physician. On the other hand, if you're sane, you're not crazy, but you work hard and you work very hard, but you're nice and you want, then you somehow maybe get to, well, I don't know, you get it back over here to pediatrics or medicine if you're nice. That's kind of cool. But if like, your attitude, it doesn't really matter, you don't have much of an attitude, well then, depending on what you want your patient asleep or dead, you either go into anesthesia or pathology. But for me, it's always the same. You're hardworking and your attitude, you're very hardworking, and then you're mean, and then you go into surgery. So this is really, for a couple of laughs here because it's kind of the stereotypes that one thinks of, but certainly not what I would want my surgeon to be. But so I remind, I want students as they're thinking about medical school and then in medical school to keep an open mind. I certainly did when I was thinking about what I wanted to do, because there's a lot of cool things out there. And I know a lot of people who'll be watching this video, have already said, I want to be a gastroenterologist or I want to be a neurologist. I like neuroscience. And that's great. It's great that you have an interest. And I think it shows that you've kind of been paying attention when you're shadowing experiences and all. But most people who say that before medical school don't end up doing what they said they were going in because they just fall in love with something else. So stay calm and always keep an open mind as you're thinking about this stuff. So how do we get to vascular surgery? Here are the years. These are the number of years. So college, 4 years, right? We get that. 4 years in medical school. And this is the traditional path. And I'm going to show you in a minute that we have two paths now to vascular surgery. But this is certainly the path that I took back in the 80s on my journey to becoming a vascular surgeon. 4 years of medical school followed by 5 years of a general surgery residency. And at the end of that time, I had to take my boards in general surgery. And so I became a board certified general surgeon. And I could have gone out and practiced general surgery at that time. But instead, I chose to do a fellowship, which in my case was just a 1-year fellowship, but most these days are 2-year fellowships. And then following that, then you take an additional board exam. And so I then became board certified in vascular surgery. And so I was dual boarded, if you will, general surgery and vascular surgery. Now, in the old days, the vascular boards were what was called an added qualifications. A little bit of a nuance. Doesn't matter. It's like having two boards. And then a lot of research fellowships, or even some time during residency, particularly if you want to go for a competitive fellowship, requires 1 or 2 years in the lab. Just not to check the box, but more because that's what your career is going to be like, and you want to have those kinds of experiences. So I didn't add this up because it's a lot, but I can tell people it goes by quickly, and this should in never way be determinant of what you want to do. Forget the number of years. It doesn't matter. Once you get through it, that's all that counts. That's your career is what counts. This is easy stuff to get through. And, you know, I had a professor, actually, the guy who was my first role model, he used to always say every year at graduation, at our residency graduation, he'd say the same thing. He'd look me in the eye, shake my hand, and he'd say, the days are long and the years are short. And that's true. I mean, that's really, you know, it's like you're at graduation, you feel like, oh, I was just here last year. But in the middle of a day, when you're a general surgery resident and you got to get through the next 12 hours, you really, how am I going to get through the next 12 hours? It's like you can't even figure it out, but you do, and everybody does. So to always keep that in mind, keep the goal in mind. So this is what general surgery training looks like now, modern day training. You can do what I did, which is a traditional program, 5+2, which is 5 years of general surgery, take the general surgery boards, and then 2 years of a vascular fellowship with optional research. This is about what, about right now, about 80%, I don't know, 70% of students are doing. This is the pathway that they're taking to vascular surgery. But within the last 10 years or so, there's been the introduction of a so-called integrated pathway, or 0+5. So you'll hear people talking about 5+2 versus 0+5. This is how people in the field talk about it. So this is a combined integrated program now. You don't go to a general surgery residency. You go to a program that's kind of housed within a general surgery residency, but you get treated differently than the general surgery resident. You're in a different track, if you will. And you do lots of general surgery cases, but not nearly as many as the general surgery residents, and not really the really complicated ones, because it doesn't make a lot of sense for you to train to do super complicated GI surgery when you're never going to do that in your practice. Now, when I trained to be a vascular surgeon, there were a lot of surgeons who did in their practice both vascular and general surgery. That was common. Fast forward to now, uncommon. Vascular surgeons really just do vascular surgery. They don't do general surgery. Now, the exception to that would be if you go out into rural America, there's plenty of people, plenty of great surgeons who do both. They do vascular and general because, I mean, if they don't do it, no one's doing it. So, but for the most part, in any major city, you get your vascular surgeons, you have your general surgeons. So no general surgery boards. The whole program here is 5 years. You come out, you're a vascular surgeon, unless you've taken 1 or 2 years of optional research.
All right, so my name's Hillary McCray. I'm a resident physician at the University of Utah, where I'm doing a 5-year training program in otolaryngology head and neck surgery. And so you might be asking yourself when you see the slide, what is otolaryngology head and neck surgery? And might not know much about that. So I'm going to kind of give you a brief preview of what I do on a day-to-day basis. So kind of when you look at what is on the national websites in terms of the American College of Surgeons. So otolaryngology is a type of surgical subspecialty. And you kind of look at how they define what our career is. And really kind of the emphasis of what I do on a day-to-day basis as a head and neck surgeon is I am trained to take care of the surgical and medical needs of patients that are presenting with various different types of head and neck pathologies. And kind of what that means in terms of what types of disorders and anatomy I'm dealing with is, so it could be anywhere from an ear infection that has gotten very complicated and is approaching the skull base, could be a respiratory infection that's causing acute stridor, or anything that's kind of causing obstruction in the nose and the upper airway. And really, we're dealing with some very complex anatomy and diseases in the head and neck, which is kind of the appeal for a lot of people that are interested in a career in head and neck. But really, how the American College of Surgeons defines what an otolaryngologist does is they basically said that we are understanding the basic medical science relevant to the head and neck, and how that can, go on to affect your ability to hear, your ability to communicate with one another, and your chemical senses. And one of the things that really drew me to a career in ENT is that I deal with people's innate senses, whether that's their ability to smell, their ability to hear, their ability to see. All of those things we really are able to have a direct impact on our patients. And so, we're able to take our medical expertise of this very complex area and then offer complex surgical solutions to patients that have a variety of head and neck needs. And those can range from, doing a simple tympanoplasty for someone that has a hole in their eardrum, or if it's someone that has a very complex cancer that's invading, somewhere in their oral cavity, like their tongue, and then it has, disease that's spreading to their neck. We're able to really address all of those very complex needs for our patients. And so what does the training entail? So like any surgical subspecialty, that usually has a minimum of 5 years. So I'm in a 5-year training program. The first year, your intern year of residency, is spent usually doing 6 months of otolaryngology and then 6 months of training with either plastic surgery, neurosurgery, which we both, we work very closely with our neurosurgeons for a lot of different types of complex cases. General surgery, kind of learning how to take care of, post-operative needs among children and adults that are having different types of general surgery. Intensive care is also an innate part of your intern training. Usually we do about 2 to 3 months of intensive care. In terms of my training, I spent time in the burn unit, on a surgical shock trauma unit, and then in the neuro ICU as well. And then we also work with our anesthesiologist, because airway management is a pretty large part of what we do as otolaryngologists. We're kind of the airway emergency experts in addition to our anesthesia colleagues. And so really it's that, relationship with other specialties that kind of allow you to build on the skills that you need to be successful as an intern. And then research is also an innate part of what we do as otolaryngologists. I think, anyone that's considering a career in ENT has some, interest in kind of expanding the medical knowledge about our field. And so usually there's some sort of research component built into your residency education. For me, I do about 6 months of research that's kind of spread out over the course of the 5 years, but there are some programs where you can do just a year of dedicated research, or even 2 years where you're under a special grant that allows you to kind of expand research opportunities on the national level. And then really the training, like we had kind of previously talked about, is a mix of operative experience and clinic time. And it's kind of, the ability to take care of patients in both of those capacities. It's very fulfilling. So what are the subspecialties of otolaryngology? So there are a lot of them, and you can go on after your 5 years of training to go ahead and do a fellowship. One of them, it could be rhinology or skull-based training. So any diseases that affect the sinuses, the nose, nasal obstruction, or even tumors that are going, in around the sinuses and kind of invading up near the skull base. And that's when we could kind of collaborate with our neurosurgery colleagues. You could go on to be a facial plastics and reconstructive surgeon, so addressing the various cosmetic needs of patients, anywhere in the head and neck. And, also associated with that is the reconstruction. So either, with local flaps or free flaps, which I can kind of talk about a little bit later, head and neck surgical oncology, which is my field of choice and what I will be applying to fellowship in. And really, you are a head and neck cancer surgeon, and you deal with patients that come in with a variety of head and neck cancer needs, or even endocrine needs in terms of thyroid, parathyroid care. And then also you're trained to be the reconstructive surgeon for those. And so sometimes that means that you're taking, someone's thigh and reconstructing their tongue, or, taking part of their forearm and reconstructing their tongue, and then doing the associated microvascular reconstruction for that. And really it's a fascinating field, which is why I chose ENT in the first place, was because of head and neck surgery. Laryngology is addressing people's voice and airway surgery concerns. So people that have, difficulty breathing due to narrowing of their airway, or if they have, a particular injury to their recurrent laryngeal nerve that causes them to have a vocal fold paralysis. Being a laryngologist allows you to kind of, improve their quality of life related to voice and breathing. Neurotology and otology is what you would consider an ear surgeon. So they're trained on kind of lateral skull base, and then any ear needs, including cochlear implants, which have a massive impact on the quality of life of other people that have, deafness or hearing concerns. And so really that, again, has a massive impact on people's quality of life. Pediatric otolaryngology, which I'm currently a resident on that service. So you're addressing basically all of the head and neck concerns among children. And so they're kind of like skilled in providing complex head and neck care to patients that have acute sinus concerns or a neck infection or even hearing concerns. And so they are able to take care of many different aspects of children with unique needs. And then sleep medicine and surgery is kind of a growing fellowship within our field. So you can offer surgical options for patients with really bad obstructive sleep apnea. And overall, most of these fellowships are 1 year. So most otolaryngologists that are fellowship trained will be done in about 6 years. Neurotology is 2 years, and then some head and neck fellowships, some facial plastic fellowships could be 2 years as well. So what does my day look like? I round pretty early. I get up pretty early. I usually get up around 5 a.m., 5:30. I go in, I round. I'm currently the chief on the pediatric otolaryngology service. So I meet up with my other residents on my service. We see our patients. And then around 7 to 8, we talk to the attendings about their patients. And then we go to the operating room or the clinic. Usually, if I'm in the OR, I'm there pretty much all day dealing with add-on cases. I could also be in the clinic seeing patients for new consults or postoperative needs. And then we round again in the afternoon, go see how our patients are doing throughout the day. In terms of call, we are consultants. And so we get consulted by various medicine specialties or surgical specialties and the ER to come and see patients with a variety of head and neck needs. And so that's another aspect of being an otolaryngologist is you're a consultant that goes sees, people that have, acute head and neck needs.